Good morning and welcome to these Business Day Dialogues in partnership with ASI Financial Services. I'm Joanne Joseph. For the next hour and a half, I'll be facilitating this conversation on the future of healthcare in our country. By now, you're familiar with the National Health Insurance concept, which government has been promoting with a view to establishing universal healthcare in South Africa in the coming years. You probably also know that the National Assembly passed the NHI Bill on the 12th of June, and it's now sitting in the National Council of Provinces for further debate and discussion. So it's not a question of whether the NHI will ever become a reality. It will almost certainly, even if that takes a good number of years to realize. Some of the other questions that arise include: how long will it take for the bill to be enacted, then implemented? What will the healthcare landscape look like once the NHI is in place? And most importantly, what will it mean for you and me as far as the provision of health services goes? While it extends quality healthcare to disadvantaged groups, does it mean those paying for access to private medical aids in the country will be disadvantaged? These are some of the questions we're going to tackle today. Now, I'm sure you have many more, so please make sure that you're using the chat function. If you are joining us online, we welcome you too. We're also delighted to have many of our audience members in the room with us. Good morning and welcome once again. And later on, we're going to be sending a roving mic around to source some questions from our audience in the room while we integrate those with questions from our audience online. I'll introduce you to the eminent panel we have with us this morning in just a moment. For now, though, I'd like to ask Mr. Anthony Govender, the founder and Group CEO of ASI Financial Services, to please come up to welcome you.
That the NHI policy, its intent, the spirit behind it is something that we are firmly in support of. Does the policy need some refinement? Does it need further consideration? Absolutely it does. Am I fully supportive of having a single fund that purchases healthcare on behalf of all South Africans? The short answer is absolutely yes. So I want to say emphatically that we're in support of NHI. And Nicholas, I want you to know this, that I believe that your view of having a single fund that purchases healthcare in the country is absolutely what South Africa needs. Do we have sufficient clarity? Do we have sufficient detail? And I think the strong answer to that is no. And so I suppose today is about giving us some of that context. Now, this might be a view that's contrarian to what some of the private sector players have communicated in the media. I'd like to just relay some of this from personal experience. I'm a township kid, and when I consider policy for the country, so don't let the suit fool you. When I consider policy and what's good for all South Africans, I've got to think about what's good for my grandmother's homeland, where basic services still lack. And so we got to think not just about the private healthcare sector, and you and I who are members of medical aids, but also, very importantly, those people that come from very disadvantaged communities. I think secondly, and very importantly, what we want to talk about, these timelines and how does it impact you in business. We have a number of decision makers in the room today, and I suppose the question that's weighing on your mind is, how does this impact my company? How does this impact my employees? What do I need to do to adapt and pivot, considering these significant changes in terms of the healthcare framework? And as a third part, very importantly, is talking about alternative solutions and where do we actually go over the next sort of 5 to 10 years. Now, it's important that we all understand that the national health insurance system is not going to come through overnight. It's certainly not going to impact us in the next month or the next 3 months. There's a whole process. At the point of Nicholas starting, he's already been taken to court a few times. So he's got a really challenging role ahead of him. But I think it's important that we get behind Brand South Africa and we get behind the national health agenda. The challenge that we have within the private healthcare sector in particular is that we all want change, and if you hear that there's a golden thread and narrative that flows through the country, we are absolutely in support of NHI. We are absolutely in support of the bill, and that but comes from commercial interest. It's how does it impact me and my pocket? And that's the issue that we need to address today. And we've got to be very open and honest about this. If we are going to support policy with a commercial intent that it suits and favors only a select few of businesses, this is certainly not going to be good for South Africa. But at the same time, we need to address this undertone of mistrust that comes from public. If you had to ask me today, would I be confident to go to a public facility? Coming here this morning, we caught the headlines of the Tembisa Hospital and the irregular governance and the fraud and corruption that exists in the state. I wouldn't be confident placing the well-being of myself and my family in the hands of state. Not now, possibly in the future. And I think the conversation piece has to be, how are we going to address these issues of public trust? How are we going to ensure that we protect the rights of South Africans and allow them choice? If I want to go to a private hospital and I'm prepared to pay for it. And once again, speaking from experience, having experienced COVID firsthand, ending up in an ICU, I chose to go to a Netcare hospital. I want to have that same choice. And Prelisha this morning, Teshlin this morning, is going to talk very specifically to these kind of issues. What are our constitutional rights? What are our legal rights? As citizens of the country and as medical aid members. There's also some fear from public that the money that we have contributed into the reserves of medical schemes are going to be taken by government. And I want to stress this point up front, that government is not allowed to touch your monies. Medical schemes belong to you and I as medical aid members, not to medical scheme administrators, certainly not the insurance brands out there. They belong to us as members. And I think it's time that you and I, as the private medical aid members of the country, start taking some ownership and accountability and taking our responsibility in when it comes to electing trustees and it comes to the management of these medical schemes, and start steering the direction of where these medical schemes need to go to. And with those opening remarks and sentiments, I'm going to hand back to Joanne, and let's get the show on the road. I'm pretty excited about having this conversation, Joanne.
Thank you, Anthony. Well, so am I. And so are all of the guests I'm about to introduce to you, because we certainly have some experts on the panel today. I'm going to start with you, Professor Nicholas Crisp. I know you just want to be called Nicholas. Medical doctor by profession, Deputy Director General of the NHI. Welcome to you, Nicholas. Lovely to have you with us. Yeah. There's Prelisha Singh, the Head of Public Law at Webber Wentzel. Looking forward to hearing your input there, Prelisha. Dr. Stanley Moloabi, Qualified Medical Practitioner and GEMS Principal Officer. And Mr. Teshlin Akaloo, serving as the Managing Director of NetcarePlus, a division of Netcare, South Africa's largest healthcare provider. So let's get right in. Nicholas, I think it's fair to say the NHI, or the notion around the NHI, invokes quite contradictory feelings in South Africans, depending on who you are. Trust, mistrust, fear, hope, uncertainty, they're all in the mix. What are you actually trying to achieve with the NHI?
Okay, thanks very much, Joanne, and good morning to everybody. Morning to my fellow panelists, and thank you, Anthony, for the invitation. So what we are trying to achieve is to fix the very messy, very expensive, very complicated, and highly unproductive health system we have in the country. We have a dual health system. In the private sector, we have 72 medical schemes with 308 different options. Nobody knows what cover they've actually got. Many of us will only discover what our cover is or isn't the day we get sick and we need that health care. And we're ending up with people spending more and more out of pocket because they can't afford to pay in advance for their health care. And on the other side, we've got 10 government health departments, the National Department, which is very small and really deals with policy and international matters and standards. And then we've got 9 provincial health departments who are not funded through the National Health Department, but are funded through provincial governments, and who each do something independently and duplicate what the others are doing. So it's a very messy space. There are other players, correctional services, Defence Force, and some municipalities, especially the metros. So it's a very messy space. It's very expensive, it's very duplicative, and none of us really gets what we should be getting. We have an extremely unequal society, as we know. We have the highest Gini coefficient of all countries in the world, which means that wealth and income are concentrated. So what we want to do is to create one health system. You can be many players. You can be a private provider, or the suppliers of all the goods are private anyway. But we need to have one place where we buy, where you and I and the person on the street corner know that when we get sick with a particular condition, we will be treated because we need that health care. Not because I've got money or because I've got a nice warm bed in some rosy suburb or I'm treated differently because I'm on the street. We have to look after everybody because that's what our Bill of Rights says, and we need to do it in a way where we know and can trust the quality of what we're doing. Now, that's a big ask. It's a big mess that we need to deal with, so we need to deal with it systematically. But you need a framework. You need to have a process that you're going to embark on, and that's what the NHI is about. We'll get into the details.
Well, thanks for that high-level summary, Nicholas. Teshlin, how necessary and attainable is universal healthcare in South Africa?
And good morning, Joanne, and thank you for the question. Good morning, panelists. I think we all agree that universal healthcare is a must in South Africa. Access to basic healthcare is a basic human right, like Dr. Crisp said as well. I joined Netcare, Joanne, because of our will to solve for accessibility to healthcare. I joined Netcare just before COVID, the dreaded pandemic, but we still continue to actually create solutions to actually ensure more people can access quality healthcare. That hasn't changed. That will always be the case. And as Netcare, our mantra is the sanctity of life. We preserve life, and we will do that first and foremost at all costs.
Anthony, why couldn't we just fix up the National Health Department and the healthcare currently? Why would we need to integrate the systems?
Joanne, I love the example that Nicholas uses. If you had to live in Diepsloot and I lived in Stain City, which I don't, disclaimer. And if we both had a similar illness that required tertiary care, as a patient requiring a care, the fact that you didn't have a medical aid, you're likely to be admitted by an ambulance, a private ambulance, and you'd have to go to a Charlotte Matseke or a Tembisa hospital, whereas I'd have the luxury of traveling, for about 1 kilometer and getting to Fourways Life. And I think that's the inequality and disparity that we need to address. Should we be profiting from life? And the reality is hospital groups like Life Healthcare, Netcare, Mediclinic amongst others, is a national asset. It is an asset to South Africa, and it's certainly something that we shouldn't break. We can't build public healthcare at the expense of breaking the private healthcare infrastructure. And I think both parties are saying the same thing. Private sector is saying we're happy to collaborate and support the agenda. Public says we need you to support the agenda, and I think there's a willingness from both parties. I think what people don't understand about the NHI Bill is that, for the most part, and Nicholas can maybe expand on this, the NHI Bill focuses on the reform within public sector first. That's where the priority is going to start. We're going to take this 260 or 270 billion rand that we currently spend as public expenditure in state, and look at the best way we can optimize value for the South African healthcare consumer. But more importantly, I think for a number of the medical aid members sitting in this room and those of them watching online, we receive medical aid tax credits. And once again, there's two views. There's the views of the 9 million South Africans that are covered by private healthcare, and then those 51 million people that are not covered by the system, the private healthcare system, that go, should you be benefiting from a tax credit on healthcare? And so there's roughly about 34 billion rand. And I think we hinted this 2 years ago when we had a similar engagement about NHI, where we said there's likely to be an abolishment of tax credit. For the most part, medical aid premiums are paid as a fringe benefit premium into the system. And so government intends moving some of or all of that money in tax relief into the public spend and utilizing that to improve state infrastructure. But in short, Joanne, the idea is for both private and public to work together and not breaking one system at the expense of the other.
So there are a couple of aspects there that I want to tackle. Prelisha, this segues very nicely to the question I was going to ask you about this very real fear, firstly, that in trying to achieve universal healthcare, government inadvertently destroys one of the best private healthcare systems in the world, arguably, in South Africa.
Good morning, everyone. Thank you, Joanne. I think I want to probably challenge you on that statement. Contrary to the fact that I represent mostly the private sector, although I've represented NIC as well, Our systems are equally dysfunctional, but in different ways. And I think what we currently have is extreme challenges in both the public and the private healthcare systems with huge inbuilt inefficiencies. Neither of the systems is optimal. And it's something that I think as a starting point we need to recognize. And in both systems, transformation is key. Whether this particular mechanism is the appropriate one to achieve that transformation is where I do differ with Nicholas often. We started by saying, or Nicholas pointed to the Gini coefficient. There's a saying from Mahatma Gandhi around the truest measure of a society by the means by which the most vulnerable is actually taken care of. The Gini coefficient came many years later to almost encapsulate what he was saying. And here we are the most unequal society in the world. We have two systems, one seemingly working very well and one working very badly. But I actually believe that both have deep challenges in each of the systems. Whether then the disruption that the NHI Bill, which I believe is necessary and laudable in its intent, is going to actually achieve the balancing of the playing fields such that we will then have universal access to quality healthcare for all. Therein, I believe there are hold some reservations. We're going to then have to do massive amounts of change in both. And I think it's the uncertainty as to what that change will actually look like in both systems that gives rise to that statement, but aren't we going to ruin X? I think that we might not be ruining X, but I'm not necessarily sure that we're going to be improving Y, that is the access to healthcare for all. I think for me, if you allow me, I believe that the mechanism suffers three challenges. One is that it's a bit ill-suited for our context. And I liked what Anthony said earlier, that he is supportive of NHI. I am supportive of universal access to quality healthcare. I don't necessarily believe that the mechanism or vehicle of NHI is what is going to attain that.
Why not? On what grounds?
I have many points.
Okay.
Whole page here. The first is that I think it's ill-suited to our context by virtue of our history, our huge capacity constraints, our limited tax base, and our high disease burden. I think that, for me, puts a nationalized system at huge disadvantage, actually, and might then, through those additional challenges that might not exist in other jurisdictions that have been tested with a national system, would cause that here it might not fit our need. Secondly, and I'll probably turn to this later, I believe, and I have some reservations around the constitutionality and lawfulness of the bill. And we have the most progressive constitution in the world. It has the entrenched right to access to healthcare, but that applies to both. It applies in this scenario to medical schemes, it applies to private healthcare users as well. And the third is I harbor concerns around the funding and whether this will be affordable. Is it something that we can actually afford as a society? And I have concerns as to where the money is actually going to come from. I don't want to get into the cynical debate around corruption and, concentrating of the funds and, this, fear-mongering that I think has developed out of it, because I believe that there's distrust and suspicion from both sides, and the debate has become one of juxtaposition, private versus public, poor versus rich. And I believe that's noise, actually, around the NHI. I believe most people want to see all fellow human beings treated with dignity and respect and have access to healthcare. But I think that in that debate, that's why I asked Nick earlier if the Council of Provinces is holding consultations. I think that both the private and public sector together can work on solutions that might be slightly better than what NHI is postulating in the bill.
So you've opened the door to so many of the nuanced aspects of this, pardon me. But let's talk about collaboration first of all. Stan, if the NHI is to take root, how important would collaboration be in making it a reality? And would that collaboration be possible in this kind of very binary environment that Prelisha has referred to?
Well, it's as if, Joanne, you had seen what I had. Collaboration, which I often refer to as do nadering, a typical South African term. We need to work together. There's no doubt about it. Otherwise, we will not achieve, the ideals of this better for all South African context. So what is it that we want to achieve in terms of the universal healthcare coverage? We know that we want to improve the population health. We want to improve the costs that are incurred in the delivery of healthcare. We want to look at clinical outcomes that are better than we are achieving at the moment. But I think most of all, advancing health equity. Now, reference has been made to the fact that we are an unequal society, and what people get in the private healthcare is completely different from what we get in public sector. But I want to surprise you with a few statistics that I've actually prepared. So according to the World Bank 2021 Development Indicators, there's a difference of about 30 years on life expectancy between the developed countries and the developing countries. And with Canada being the example at about 83 years average, Chad at 54.4. And this is a surprise. South Africa, we're at about 65. Yeah. So we are at least 20, the difference, as opposed to most, which is 30. Yeah. But some other statistics, in terms of the universal healthcare service coverage, we scored 67%. A C is not bad.
Well,
in terms of out-of-pocket payments, the entire population, South Africa spends about 5.36 in 2020. The world average is at about 16%. So we're not that bad at all. So the point I'm trying to make is that we are not as bad as we paint ourselves to be. And I think that's the South African thing. We're very bad at public relations in terms of our countries. But we must recognize, despite this nice metrics that I've just shared with you, what we need to recognize, there is a huge disparity in terms of access to quality health care. But those statistics tell you that there's something we are doing right, and that is what we must not lose. So that is good in the current healthcare systems. We must do everything to preserve, and that we can do via collaboration between the public health system and the private healthcare system. And anyway, we have proved it. During COVID, did we not collaborate? Mm-hmm. There was a huge collaboration between the private sector and the public. So collaboration is something we must look at. What we need to do, let's take out the uncertainty that is around how this whole thing is going to evolve. And I think that is the biggest challenge.
Mm-hmm. Joanne, if I could just chime in here, and maybe just latching on to what Stan was saying in terms of South Africa is not bad at everything. And more specifically, government. Often government gets a bad rap that they don't really have the competency and skills and leadership to run institutions. The Government Employees Medical Scheme is a government-sponsored fund. Government is the employer behind all government employees belonging to this medical scheme. In fact, at the start of the Government Employees Medical Scheme, and Stan would smile at this point, is that the Government Employees Medical Scheme was almost predicted to fail from the outset. Fast forward, a decade and a half, 2 decades later, it is the second largest medical scheme in the country. It is solvent. It purchases private health care for its members. It's incredibly well run. Like any other medical scheme, it's had its challenges, but it's got a very competent management team. And I think that's the critical issue that we've got to hone in on. It's not about public and private. It's about having the right skills, the right competency, the right leadership, within government to lead these funds. Because government has created its own problems. Eskom, a great example. The South African Post Office, another example. And so, Nicholas has commented this on more than once, that government has failed in a number of areas. But it doesn't mean that they can't do well. There has to be the collaboration. And we'd like to see more success stories within South Africa. I think I speak for every person in this room, every South African in the country, when we say we want brand South Africa to succeed. The only way we can succeed is to get the right people into the right positions, and we've got to get the politicians out. This cadre deployment doesn't work for us. The cadre deployment doesn't work for us. We can't have politicians run our national assets. Now, I said this to Nicholas, I'm firmly in support of what he is trying to do as a national health agenda. My concern is post him going into retirement, he was pulled out of retirement. He was in semi-retirement. And so we're very appreciative of his leadership in the country. But what happens after Nicholas? This is not going to be done by one person. We need a team of people, and he's already being challenged in terms of building the capacity that the Department of Health needs to get this off the ground. And so I think the collaboration is needed. Do we have skills and competency? You only need to look at great medical scheme administrators like a Discovery Health, like a Metropolitan Momentum. We've got some really, really great private institutions in the country. We've got the skills, we've got the leadership competency, we've got to rely on them to support the initiative. And I think the collaboration, the dialogue is essential. But I also just want to latch on to this other point, which is the private sector often points the finger at public and go, there's corruption, there's fraud. If you looked at the health market inquiry findings, and I really wish that the private sector spent as much time driving PR in it, the findings were scathing, right? And the reality is a lot of medical aid members, private healthcare patients, were fleeced. We must acknowledge that. The private sector has its own problems. There is corruption and scandals in the private sector, and it's there for a week, and then it disappears the very next day. Nicholas shared with me an example this morning. We had a Steinhoff, we had an EOH, there's the Tongaat Hewlett. There are scandals all the time. So even the private sector has problems. The reality for us is that we need to work together, and we need to adopt a certain ethical and moral framework in business that's going to help the country progress and stop the finger pointing.
I want to get into the issue of price and affordability now, because there's still quite a lot to cover. Nicholas, can I start with you? We know the NHI is not going to come cheap. We know that it hasn't been fully priced yet. There's a money bill coming. The Health Ministry and Treasury have got to work out between them how they're going to structure this from a cost point of view. But let's talk about the single funding model that you are looking at, and from a practical point of view, what that would potentially mean at this preliminary stage in terms of who controls the budgets and what goes where. And I'm asking that within the context of what Stan and Anthony have just said in regard to who holds the purse strings.
Okay, so thanks. Obviously, everybody's concerned about what we pay for what, and it's not only about healthcare. We spend 8.5% of our GDP on healthcare in South Africa. Now, that is substantially higher than our peers around the world, who spend around about 6.5% of their GDP. I'm talking about peers now. Everybody likes to quote the US. The US spent 20% of their GDP on healthcare last year. 43% of the world's health spending, one country. 43% of the world's spending. So please don't look at the US, don't look at what they do, but unfortunately that's the model of our private sector. Everybody looks at the UK and Canada and Australia and other OECD countries, but we need to look at our peers. What do peers spend on healthcare? And what are their outcomes? We have the same infant mortality rate as Ghana. Ghana spends a fraction of their GDP on healthcare that we do, and their GDP is much smaller than ours. So the question is, what do we do with that 8.5% of GDP, and what's it worth? So we spend, you heard, about 265 billion is currently allocated through our taxes, through the 10 health departments, plus the Defence Force and the correctional services and all the other bits and pieces I spoke about. So it's about 265 billion, about 4.1% of GDP, and that is 15% of government spending at the moment, government spending. And that serves the 85% of the population on an everyday basis. And don't believe about 25 and 30% of the public use the private sector. They go occasionally to a GP and a pharmacy and whatever, so they write in the report that they've been to the private sector. But they don't go to hospital. They won't go to Netcare. They'll go to the public sector because they're going to have to pay at Netcare. Right. So what happens on the other side is a little bit more money. It's about 275, 277 billion we spend as South Africans in the private sector. The bulk of that, about 85% of that, is spent through prepayment through medical schemes. The rest is in out-of-pocket payment and 1% on these insurance products, which we don't like. They're complicated because they're not regulated in the way they should be regulated. So in that medical scheme environment, the cost of administering the money, not of administering practices and hospitals and whatever, which is the efficiency issues that Netcare and others would have to deal with. Just of administering the money is 15%. So before your money that you and I pay to a medical scheme, or to whether it's a comprehensive package or whether it's a hospital plan, before 1 cent is spent on our healthcare, 15% has been consumed in paying the administrator to do the necessary work of checking whether I've got must I do a pre-authorization, and do I qualify for this screw and that tablet and this whatever, because the 308 packages are complicated. We also have to have the switches between them, because there are 72 medical schemes, but a practitioner has to be getting their money from one of these medical schemes. So the administration of all of that is incredibly expensive. Every medical scheme must have a board of trustees. Those trustees must be paid. They must have a principal officer. They must do various things to comply with the law. So I'm not blaming them. I'm just saying it's an extremely expensive space. Now, all of that money, if you have one fund, we don't have 308 packages anymore. We have one package. Everybody qualifies for this set of benefits. Now it's easy. You remove all that other administrative cost. The Indonesians, who have 260 million people on their national health insurance, told us it costs 2.8% to administer their fund. So that's where some of the money goes. So if you ask, what will it cost? It will cost 8.5% or less, because that's what we must spend. If you take the current spend in the private sector and multiply it by the entire population, we need 1.3 trillion. Well, that's 85% of the government's GDP, of our spend in a year. I mean, it's crazy. You can't work like that. But to continue to spend 5,200 Rand per capita in the public sector and 27,000 Rand per capita in the private sector per annum, go and read the Health Market Inquiry. It says you've got 4 times the global spend on, or the 4 times the amount of tonsillectomies, grommets. You've got the highest cesarean section rate in the world by far. There's waste in our system. We duplicate x-rays, we duplicate lab results, we reopen a file every time we see a patient. So the NHI Bill, and everybody doesn't read those clauses, says we're going to centralize in Section 32 the national budgets of the government. One health budget. We haven't had that since 1993. When was it? 96 was the last year we had one health budget. From 97, we've had 10 health budgets. Then it says that we are going to have one digital system. We're already working towards that. They're all parts of the current digital system through the link between Care Connect and the national government's digital system. We all have one interoperability framework published in the Gazette. We're well on our way into these things. So I think people read selectively or don't read the bill. I often start my talks by asking how many people have read the bill. And if it's 1%, it's a lot. So have you read the article in some media? Yes, you have. She's read the bill many times. She's one of the 5 people who always put up her hand. So we have a very unique relationship. She works for us sometimes and against us sometimes. It's the nature of the legal business. So I want to say to people, we have enough money in the system. There's definitely enough money. But what we do with it is we pour it into holes. It goes into fraud and corruption. Patients steal from the system. They steal from their medical aids. Doctors do it. People collude. These medical legal cases, we know that about 50% of the medical legal cases are trumped up. There's collusion in them. And that's why the SIU is investigating all of them. If we clean up our systems, not public or private, as Prelisha said, the one thing we definitely do agree on, we have to clean up both of them. We have to make them work. We have to collaborate like we did during COVID. We have to make sure that the deep slurred patient can go to the hospital down the road and not have to go all the way to Charlotte Macheke and jam up the system. So I think people must not get stuck with one element of the NHI Bill. It's big, it's complicated, it's complex, and it needs to be done systematically over a long period of time.
Teshlin, I'm keen to hear from you, because we haven't heard too much from you so far, but I mean, presumably the private healthcare sector would much rather take a multi-funding approach. What is your stance on this, single funding or multi-funding?
It's a great question, Joanne, and I think before I answer it, I just want to share the sentiments that my panelists have shared. Collaboration is key for us to get this right. We need to recognize that 1 + 1 will equal 3. And if we do not get that right, I think we're doomed for failure in this entire journey that we have to go through. You mentioned at the start of the session, Nicholas, that Indonesia took 12 years and that was the fastest in the world. We're going to step through this process, which means that we will have a multi-funded approach as we step through this process.
Yes.
We need to have conviction that we will get onto the other side looking better than where we look today. And that's the key ingredient for us to be successful in this. NHI aside, if you look at the current funding model that we have in South Africa, it's actually multi-funded. There are a plethora of products, not just the schemes that people buy to actually get access to private healthcare. It is a complicated space. And where we sit right now is we find the need for partnering with proper healthcare consultants to solve this healthcare funding problem is actually key. So where we are right now, we have medical schemes, and we keep on referring to the 9 million people that belong to a scheme. But we have products like gap cover, we've got products like accident cover, and people are actually using different mechanisms to get the healthcare that they want. At the end of the day, they're trying to solve for a certain level of certainty that if I get sick, I can come out the other side being able to operate at the end of the day. So I believe, Nicholas, that we will have a multi-funded approach. There will be some level of choice over time as we step through this, and there will be some level of buy-ups. To solve it tomorrow by a single fund, I'm not so sure whether we're going to achieve that. We're going to have to step through this together, and the best way to weather the storm is have the right partners.
Joanne, if I could chime into this one, I think the major sort of bone of contention between the private sector and public sector, it's very two specific parts of the bill, which is Section 32 and Section 33. Let's place emphasis on Section 33 that talks about a single fund and, government or the Department of Health sort of being the single purchaser of pharma, amongst others, in the country. The provision of services is still going to be run regionally by province, and Nicholas can expand on this. But I think, back to Teshlin's point on single fund or multi-fund, the reality, introducing a single fund tomorrow will not work for us. We just don't have the capacity. The country's not ready for it. We don't have the administration capabilities. Right. And so we're going to have to adopt a hybrid model and work towards a single fund. I think what my private sector colleagues are looking for, and I've been listening to a number of the interviews being run by some of the major medical insurance companies or administrators. They all want clarity, and they all want certainty, and they need to understand the role that they're going to play. And so our preference, from an ASI house view is, yes, we should go ahead with a single fund. It makes absolute business sense. It gives you economies of scale, and anyone in business would understand. A bigger checkbook buying more product gives you a better price. It makes commercial sense. However, we're not ready for it. And so it's the timeline to implementation that requires discussion. It is the approach that requires further consideration. And I think government, and this is a caution to government, you cannot alienate the private sector. And I think this has been the discomfort by some of my colleagues, like Dr. Ryan Nosh, is that he's gone, I've given you a 300-page submission. Have you considered all of this? And perhaps there's more dialogue needed. Our preference in terms of an advisory business, I believe a single fund could work. Not immediately. It's going to require more time, and I think the multi-blended fund approach is going to be the best approach to use. And I think Nicholas might be very aligned to this, because the emphasis and focus has been, let's fix up public healthcare first. So the approach from government is not that we are going immediately into the private sector and unsettling their world. They're going to focus on the public system first. And so that would be my take on it. On do we prefer a multi-funded approach or a single fund approach? I think the single fund could work long term. However, in the interim, over the next sort of 5 to 7 years, the hybrid option might be the better one to be using.
As a kind of transitional.
As a transitional period.
Yes, Stan?
Maybe just to latch on to the issue of costs. And I think this is very important. I was avoiding to Anthony made me to go this direction.
I was going to make you in a moment.
He was mentioned gems.
Yeah.
And what I just want to share, Nicholas mentioned the non-healthcare costs in the current private sector environment at about 15%. And I share that our average at GEMS has been 5 to 7%. So there's quite a lot that can be done on the basis of the work that has been done. But I also
Stan, how have you done that before you go on to your next?
Our model. The model of negotiating the best possible price that we can get services at. So Anthony knows we negotiate very hard. He's one of our service providers, in
Not
our
listed on the
telemarketing
stock
environment.
exchange.
But the point about costs also that I really wanted to, we have a unique position that we occupy, the government employees medical scheme. There's a public sector employee everywhere in the country. So we are sort of a microcosm of what, if you want a sample of how the country looks like, you only have to look at HMs, and that's the employed people in general. By the way, they also take care, those families also take care of the unemployed. This is all over South Africa. Now we cover about 2 million beneficiaries, and we do a lot of things with this data that we have. Hosting, for instance, of if we were to use a product that we have amongst the options called Tanzanite 1, as a basic benefit package, it's very basic. However, it is comprehensive in that you can have access to most of the healthcare services. We did a costing, and Nicholas, we can share the numbers with you if you approach me. But I think we did a costing of, if we were to say this is the benefit package, what would it cost in an NHI environment? And the figures are very interesting and very well informing. So I think the point I'm also making is that there are pockets of the information that if we collaborate, we can share and use in terms of planning going forward from a costing perspective. Because some of the figures that are thrown around are very scary. They make everybody uncomfortable. That's not what we want in terms of our march towards universal healthcare coverage.
Joanne, if I could just latch on to this point of cost. Administration fees make up roughly 25 to 30 billion, within the private healthcare sector. You can understand why there's discomfort around this particular bill. It infringes on the profitability of these businesses. The government employees medical scheme is a Section 21 entity. It's not for profit. It's owned by its members. There's no administration business that is attached to it that is owned by government that is profiteering from this. In fact, the SPN framework within which GEMS operates is independent private sector businesses, and I can assure you, they put the squeeze on them, to get the best possible pricing and value out of it. We've got to adopt the very same at a national level for all medical scheme members. And I think this is where, Nicholas's view in terms of centralizing buying and purchasing, within the country would be good for us as healthcare consumers because it will bring down costs. I'm absolutely certain it would bring down cost if it is managed effectively. It comes back to that conversation of having the right leaders, the right skill set, the right competency. And the reality is medical aids have become too expensive for us. If I look at myself and my own family, it's becoming unaffordable. We've had these double-digit increases, for the last 2 decades, and it just hasn't been sustainable. It's only post-COVID. And the more recent communication from the Council for Medical Schemes has been, we're expecting a single-digit increase, and I think the guideline that was given was roughly 5%. So we can expect single-digit increases, and the regulator's taking a more active role, which we're very pleased about. But this might be a little bit too late, because the inflation has already been there, and most families can't afford private healthcare. It isn't accessible. I think latching onto this point of cost again, I think Nicholas and the health minister needs to seriously consider this low-cost benefit option, framework for the country. There are families that desperately want to access products and care, private health care. They're unable to do so because government isn't moving fast enough. And this has been on the minister's desk for a while, so I want to challenge...
Not been on the minister's desk at all yet.
I want to challenge government...
Let's be clear, it hasn't been on the minister's desk at all yet. It's still with the CMS, and we're waiting for them to present the findings. Let's just be clear on that, because it's subject of a court case at the moment.
No, it is.
And you can't take the minister to court when he's never seen the documents. So.
Okay, so it's sitting before the Council of Medical Schemes.
I just want to ask Nicholas, who does the CMS report into? So, the reality is there has to, the Council for Medical Schemes is a regulatory body that ultimately government has oversight from. I think whether it's the health minister that looks at it or whether it's the registrar of medical schemes that needs to look at it, in either, in either scenario, it needs to be looked at because the public needs this.
Right. Prelisha, there's a point I want to come back to which you made earlier, and it is about the constitutionality of all of this. I mean, we've got these 9 million private medical aid members in South Africa. I mean, no one wants to pay what we do pay for private medical health care. It's a grudge purchase, rather. But they incidentally, this group of people accounts for more than 50% of 57%, I think, of the country's tax base. And constitutionally, would it be proper for us to create a kind of NHI that doesn't give them the level of choice that perhaps one is entitled to in a constitutional democracy?
It's a hugely complex question, and Nick and I differ on the answer, which we're entitled to. It's how I earn money. But the very right upon which NHI is founded, the Section 27 right, operates in two dimensions. Actually, it's multifaceted. And so I do believe that the right to access to healthcare services, or the progressive realization right as Section 27 enshrines, is impacted where, for example, you now are unable to access the healthcare service provider of your choice, for which you would be very happy to pay privately for. And I believe there, and just perhaps to take a step back, a quick 101 on constitutional analysis. You have a two-part assessment in a constitutional analysis litigation. You look to see if there's an infringement of the right first, and then we move into what we call the limitations analysis. If you do find that the right is infringed, there is the Section 36 analysis that you conduct to see whether you can reasonably and justifiably limit that right. And I know that there are huge opinions being given to the department. We've similarly given opinions, but it is a debate on the complexity of the issues that get thrown into that assessment. I think there is arguably an infringement of the right, and I believe then we need to turn to the very complex limitations analysis, which ultimately talks to proportionality, really. Are there less restrictive means that could achieve the outcome, and is it proportional in its impact? And there I incline more to believe that I think it is disproportionate. We have an entrenched system that people have relied upon, which they have chosen and pay for, that now is being effectively removed. But there are other rights that are impacted, and that includes the right to property, and that applies to the medical schemes as well as administrators, as well as a right to trade and profession, which applies to the service providers. Key element in the system, the healthcare service provider. And I believe that multiplicity or triad of rights could create some tension with this bill. I want to say that I believe that this bill should not be mired in constitutional litigation. It's not going to help us if we now then rush off to challenge this bill immediately once it's proclaimed. But that's why the opportunity, I believe, rests now to have these open conversations, to present the alternatives to the department and government as to how there can be potential refining of the bill, such that perhaps we're not going to have plethora of constitutional litigation holding up the implementation. And so, yes, in short, I believe there could be arguments around constitutional and unjustifiable limitation on certain constitutional rights. This act is framework legislation. The meat comes in regulations. Unfortunately, there is a principle of constitutionality which requires the act to give sufficient guidance to those regulations, and I believe that's a further shortcoming of this bill. There's not enough guidance in it. The legislature must guide the minister in the exercise of his power later on, or her power should it become a female minister again. And there, the scant content, even in framework legislation, gives me some cause for concern. It's supposed to say things, for example, extent of benefits, extent of compensation, not rands and cents, not exact benefit package, but the principles still need to be in the primary legislation.
All right. I'm running out of time, so I'm going to press you for a few more answers, a few more short answers before we get to the questions from our audience. Nicholas, are you not going to chase some of the best healthcare providers away with a system that starts to regulate and dictate what they earn, in what environments they work, under what conditions they operate, and who they can treat?
That's exactly what it says in every country except the United States. So I'm not quite sure where they're going. If you go to New Zealand, Australia, Canada, Sweden, you get told what you may prescribe, where you may practice, how you may practice, what you're going to be paid, and so on. So I think and national health systems around the world are very restrictive. And to go to the point also about the right, which was mentioned just now. I was a member of a medical aid, which I'm no longer a member of, because the GP that I was required to go to because of the structure was so far away from my home, 110 kilometers from my home, whereas the GP nearest to my home is only 45 kilometers away. And I was told I have to go to that one because they've got a DSP with that. So who has rights of choice of access to what is very murky even now. And I think that chasing those individual small examples is not necessarily the right way to go. We have to deal with principles. There are people who have threatened to leave the country. There are people who have threatened to do all kinds of things. And look, it's their right if they want to leave the country or if they want to go and practice somewhere else. At the moment, we have a net immigration. We just can't employ people because we don't have enough budget to employ them. The markets in some places, markets for employment are quite saturated. It's not that easy to just move out of the public sector into the private sector or move out of the private sector to another country. And there are a lot of people who come here because the amount of pathology that's available for them to learn and to get experience is very high. Yeah. It's a very dynamic space around the world. So I don't think we must be threatened by it. But obviously, we'd like our colleagues to stay. We think we're all pretty well qualified. Just because I work in the public sector doesn't mean I didn't study in the same university as my colleagues. We study. We're well qualified.
Okay. I take your word for it. Teshlin, let me bring you in here. I mean, Anthony spoke about these very complex, very hierarchical kind of studies with structures within medical aid schemes that are extremely complex. We're seeing quite a number of companies, including mining companies, contracting directly with you as Netcare. Can you just explain to me what that process involves of cutting out the middleman and what sort of benefits there are for companies that choose to do that?
It's a great question, Joanne. Excuse me. And I think we get so fixated on the funding model that we forget about the procurement of healthcare services. Mm-hmm. And in my experience of being in Netcare, quite often people come to us and ask us, how can we actually satisfy our employees' healthcare needs directly with you as Netcare? Now, contracting with the provider directly gives you very different things. We are able to put on-site clinics and actually deliver care at the site of workplace, rather than we contracting with the GP that's 110 kilometers away and hoping that you're going to get the best and safest care. So quite often we use a plethora of solutions to package something that's deliberately needed by that employer. So whether it's using occupational health and safety, whether it's using wellness type of options because we own ICAS as well, or whether it's using products that we speak about, whether it's medical aid or gap cover, we can actually tailor solutions that actually fits that employer's healthcare needs. It's a very different way of looking at it. And that's why the need for healthcare consulting becomes more and more as we go into the future. Being able to actually construct solutions based on your employees' needs, yes, and making sure that you can get productivity right in your employment place of employment is actually quite key. So I think, Joanne, being able to do that through this entire period is going to be key. We're going to have to pivot around the solutions we have today. What it looks like today and what it's going to look like in 2 years' time is going to be different. Partner with the right partner to weather the storm.
And presumably, it's a lot more cost-effective to do it this way.
It is a lot more cost-effective, and obviously we work within the budgets. Most employers have a budget to work with, and we see how can we put down solutions to actually give them the productivity that they're looking for.
Mm-hmm.
I think, Jan, I just want to add to what Teshlin is saying, is that the healthcare sector, as we knew it as employers, is changing radically. And probably some advice to the employers that are here today is to start thinking about your employee value proposition. Where is your employee benefit structures moving to? The reality is what our employees ask for today. 30 years ago, if you came into a job, Nicholas, people would ask you for medical aid and pension. Today, they are asking you for PlayStation credits. The world has changed. The world has changed, but yet 40 years later, we are still sticking to medical aid and pension. Right. So we've got to think about our employees, and whether you're in the banking, technology, mining, manufacturing space, employees have very unique needs, and we've got to start thinking about the future. And we've had a number of employers come to us directly and going, don't talk to us about medical aid, don't talk to us about pension, talk to us about the future EVP. And I think there's a lot of work that needs to be done in corporate South Africa, and a massive opportunity for advisors. And so for those health brokers and advisors that are tuning in, There's no reason for you to sell your businesses to medical scheme administrators or insurance companies. You've got to pivot. You've got to understand where the markets are moving to, and we'd be happy to share with you our thoughts of where the future of advisory is moving to. Nicholas, there was a concern I think that I expressed on a call is what's going to happen to health advisors, considering the complexity of NHI and this transition that we've got to make from the current blended model, which is medical aid schemes, health insurance products, to move to a single fund, which is government's desire. You need advisors. In fact, I see so much of opportunity in work for us. You're going to be calling on us all the time. There's no need for us, but there's so much of fear, so much of anxiety, and there's no need for that. Absolutely no need for that. And I think the reality is for most employers that are operating in South Africa, whether they're international brands or local brands, you have a private healthcare sector that's absolutely committed to working with you. And importantly, you've got great advisors, not just ASI, but the many advisors, independent advisors that we have in the country that can help you steer through the complexity.
Stan, I just want to ask a question about this notion of NHI ready, which is what all facilities will have to be. They will have to be accredited. Presumably a skills audit will be done and it will be determined from one facility to another what skills gap needs to be closed in order for these institutions to become NHI ready. For you, as an outsider looking in, is that going to be a long and arduous journey before the NHI actually takes off, per se?
The word that has come through in most of what we are saying is complex. The complexity of a health environment as a whole is what comes out. Now, talking about accreditation, already there's a court case on the certificate of need. It just tells you everything that comes along during the transition period will bring some uncertainty in some instances. The fight, flight response that we often refer to, it's very, very prevalent in a changing environment where there's elements of insecurity that are brought in about these social changes. So complexity is what's driving. And we need to try our best to simplify this. The messages that go out there about what is it that we want to achieve ultimately with universal healthcare coverage, that's got to be simple. Some of the things that come out of the health market inquiry, and I think, Anthony, I agree with you, we're not giving it so much publicity as maybe because it had some damning findings about the cost of healthcare. And I think that's one of the things. So the way I look at it, we need to work together to understand what is it we want to achieve. In any social change, how you manage the transition is what will determine your success going forward. And we are in a transitional period. What we see is more fighting than working together. And if we can get the transitional period right in terms of the guidelines, we are here. What is the role of the private sector? This issue of skills that reside in the private sector, how do we use them to ensure that we work together towards that there will be people who don't like it anymore. I mean, they'll have to make choices. But at the end of the day, it cannot be that we want it to be business as usual when we're talking about how unaffordable it is to access private healthcare funding. We need to work together to try and come up with simpler funding models. And I mean, talking about things like low-cost benefit options, all of those things. The uncertainty, the unfortunate incidents that happen when you think you have an insurance product and you try and access health and they say, no, your product doesn't pay for what you need. It can be devastating for families. Yeah. So in essence, we need to work together to reach the ideals of universal healthcare coverage.
Thank you for that, Stan.
Can I just chime into this? And I think it's important that that business and all stakeholders understand this. We criticize government. We say since 1993, fast forward 30-odd years, we have not moved fast enough. We've been talking about NHI, and we haven't moved fast enough on the health agenda. The moment we put a bill in place, we go, hold on, you're moving too fast. Now we've got to decide, are we moving too fast or are we moving too slow? Right? The only issue that we have is that when the change happens, it doesn't suit certain commercial interest. It doesn't suit certain personal interest. That's the crux of the issue. The issue, for the most part, is not the bill, its intent, and the spirit behind what we are trying to do as a national health agenda. The issue is, how does it impact business? What is the transition look like? Can you give me certainty and clarity? And unfortunately, Nicholas, I think that's the path that you and the minister have to work on, is giving more clarity, to public, giving more clarity to business, so that they do feel included. And it's less so, you'd probably argue that for the last 5 to 7 years, there's been a lot of dialogue and conversation. But the fact that there's a huge sector with a number of stakeholders that feel that they haven't been included and considered as much, then perhaps we need to go through another round of conversations and dialogue without necessarily changing our stance of what we want to achieve. But let's go through that inclusive process. And I do believe that we need to move with haste and move very, very passionately.
There's a very basic question that I think our viewers will want answered, Nicholas. And many of them are probably sitting wondering, how long do I have with the current medical aid scheme I'm on? Or how long will it be before I can access universal health care, depending on who they are? Is there a straightforward answer to that?
No.
Is there a kind of nebulous target that you have in terms of what you're aiming for time-wise?
No, so the original bill that went to Parliament had 3 phases to it, and the first phase was essentially strengthening of the health system, the public health system, and then there were 2 other phases. Now in the B bill, which is the one that's been through the National Assembly and is now in the National Council of Provinces, there are 2 phases. And the first 3 years that are written in there as phase 1 is essentially setting up the capabilities, getting the digital systems in place, getting the forums together to talk to one another, getting the capacity of the administrative office in place and so on. I mean, at the moment, we are essentially 3 or 4 people in the office. We've been trying to recruit 44 people, and we've been in court with a party, that Solidarity, who's trying to stop us from recruiting people to do the work. Who's going to talk to you? Me. Me and me and me. I mean, it's crazy. It's not going to happen. So, it's exactly what Anthony is saying. How far do you get before you say, okay, now we need to engage? The second phase is now starting to say, okay, we've got some administration in place. If you look at the numbers of people who work in the administration, in the schemes and the scheme administrators, you can't compare it with our 30 or 40 people, and ours are all backroom people working on digital systems. They're not people like me who are working on policy matters. You need to have that capability. You need to have people who are able to do the engagement. That's the first 3 years. During that time, as things become clearer, you can now start to say, okay, well, we've been through every line by line in the entire health market inquiry. This is a disaster, this is a disaster, this is a disaster. What do you do about it? So dealing with a single compulsory option. It was recommended in the health market inquiry. And people tend to forget, by the way, that for the last 5 years, we all worked on COVID 100% of our time. I worked 20 hours a day for a very long period of time, trying to just work with all the colleagues to get the vaccinations and do things. We don't give ourselves credit for how much we actually got done in that time. Now we are concentrating on getting the framework in place. I have no doubt there will be amendments down the line. We have had 3 health acts in the history of South Africa, 1919, 1977, and 2003. Now we've got a piece of legislation that adds a new dimension to the Health Act of 2003. We need to give a chance. You need to work with it. And the devil is in the detail. Mm-hmm. So the answer is no. There's no final short answer. We will amend the Medical Schemes Act along the way. We will amend the Health Act along the way. We will amend many regulations along the way. And the only way you do that is by working together and watching the changes in the environment. Things will never be the same as they were in the past. But if you don't do what Anthony's saying and commit, take that first step, get on the road, work with what you've got. And by the way, the NHI Bill will not be implemented will not even be proclaimed all at the same time. Mm-hmm. The question on my desk at the moment is, what does the president sign in November? He has signed the bill, but he will only bring about 5 clauses into law. Because you can't do anything till you have a board. I'm not the board. I'm an employee of the health department. You need a board. The board needs a chairperson, a vice chairperson, and they need the committees of the boards. You need the advisory committees. You need a CEO to be appointed. The process is to do that through Section 13, where you need an ad hoc committee, interviewing people in public, in a public process. How? We have to publish the regulations first on how, or guidelines on how that's going to happen. They must be published for 3 months. Comments must come in. By the time that process is finished, it's a whole year before you've got a board and an administration and an office with a computer and a telephone and whatever. So I think this is not a short game. This is a long decision to fix this highly complicated, very expensive and duplicative system so that we all come out. Those of us who are a bit older, maybe we will see it in our old age, but others will grow into this space and reap the benefits of a good health system. There's much to fix.
Prelisha, what worries me is that just by its very nature, this process needs to take time. It needs to be a slow
Assent in November has indicated it's going to be a staggered implementation. So those pieces might take years to come into effect. They might be mired by litigation. And the regulation-making process is equally long. And the regulation-making process can be challenged and tested against a higher standard, actually. And so I do believe that we're going to have potentially forces at play that might then delay this into its full fruition. And that could come from many different sectors, not only politically, but at least once it is law and not set aside.
How it works. Health Act 63 of 1977 was the act. But that act was written for white South Africa and excluded the homelands. But the majority of the population lived in the homelands in those days, not in white South Africa. And the homelands did not have municipalities. But Health Act 63 of 1977 mostly dealt with services of municipalities. So it was very complicated. And that piece of legislation was in place until 2003, when we got a new Health Act. So during that time, provinces were operating in what space? What was regulating their health system? And there was a lot of argument about what should be a provincial function and what should be a national function. And we ended up with Section 25 of the Act of 2003 explaining what the provinces should do. Now we're in a situation where the provinces have not done well. All of them, to a greater or lesser extent, have problems. I know everybody likes to think the Western Cape's got it all wrapped up, but they never get the highest marks in the assessments of anything. They get second, they do well, on the average they're better than others, but all provinces have a problem because we've created in the Constitution 9 legislatures with their own administration, but they don't have to comply with any national policy. So now Section 33 of the NHI Bill comes along and says all health functions are removed. Go back, Section 25 of the Health Act is reformed. Take away all those services. Centralize the budgets. They don't go through the provincial equitable share anymore. They now get centralized so that we can decide again, like we used to do in 1994, how to manage the whole health system. And it says the province, the MEC of the province and the head of the province must now be the steward of the whole public and private system, but they are not the ones who are going to control the budget. We're going to buy healthcare from the public provider, from the fund, just like we would buy from a private provider. Right. This is a massive change. So provinces have become like small countries, states on their own. And it has not been good for the integration of the health system. It may have been good for other functions. So I'm not saying it's a totally redundant system. But for healthcare, it has created lots of problems. We have provinces who send accounts to other provinces. And in order to overcome the fact that Limpopo doesn't have tertiary health services and neither does Mpumalanga or Northwest, we have conditional grants so that those can pay for the service being delivered by Gauteng on behalf of those provinces. So I'm afraid it's a very long and complicated space that everybody seems to be concentrating on Section 33. That can wait, but we need a mechanism by which we can come to our colleagues in Netcare and Life and others and say, we need to buy healthcare to decongest the public health system, but the budget's sitting in the province. So we can't do that until that money is in the fund or at least controlled by the national department, because the provinces have got their own unique problems. They compete with education and agriculture and whatever. There isn't a health budget. So I'm sorry if it's a very long and complicated answer and you've only heard 2% of it. My poor students at university get the whole deal. But it is unfortunately going to be a long and hard process to get where we need to go.
Yeah, it certainly sounds like it.
Joanne, if I just add
Yes,
and
yes,
to mansplain Nick. So essentially, the first step is fixing the public health system, in short.
Parallel.
In short. And, well, you say in parallel. I probably think sequential, though, in that is almost the response of the NHI Phase 1 is to fix what, unfortunately, through the duality of the competences has caused.
So, sorry, it's a bit of a dialogue at the moment. So in order to decongest the public service, we need the spare capacity in the private sector. We know that from COVID, we knew during the time, we sat down. I mean, I was the one who negotiated the prices with the private hospitals. We know that, and we worked with Stan and his colleagues to look at what's the best and the cheapest and the fairest and the prices and whatever. And we worked with the Competition Commission to check that what we were doing was not illegal or anti-competitive. You can't fix the public sector alone because the staff are moving between the public and the private sector all the time. You need the two to be working together. You need to be able to share resources, and you need to be able to buy into the very example that we were given. Diepsloot must buy from Life Fourways. That hospital is not full. The CEO of that company has been talking to us for years about wanting to service the community of Diepsloot. And there are lots of other examples around the country, including with the CEO of Netcare and the CEO of Mediclinic and the NHN hospitals and so on. We want to work together. But it's extremely hard if you've got no money to buy it. They're not going to give it free. I mean, they do. They have their CSI projects, and they do give us some things free in the public service. But the public service, we need to be able to pay. So the systems, we need to do what's in the health market inquiry. We need to fix the things that are broken. We have to systemically deal with why there's over-servicing in the private sector. Why is everything dealt with by a specialist? When the GP is a perfectly adequate, in fact, a better doctor in many instances for the holistic care of a patient, and must use the judgment to refer the patient to the specialist. But we've designed a system where the medical schemes, it's easier for them to pay the specialist than the GP. We've also designed a system where a person with a hospital package, because that's what they can afford, must be admitted to get an investigation because then it's paid for. Why don't we just pay for it as an outpatient procedure? And those structures have to happen in parallel with the colleagues who are working in the medical schemes and the so it's not either or. There's lots of tidying up in the public sector that is indisputable. We need to get control of the infrastructure budgets. They're sitting with public works departments and all over. Hospital managers can't even manage their own maintenance budgets. They've been taken away. So there are lots and lots of things that need to happen, and it's not either or. We really have to put together our heads together as South Africans and say, I worked with Stan and his staff during COVID. I worked with Richard and I worked with others. They were our lawyers for a whole lot of stuff during COVID. We know one another. Why now suddenly can't we work together? There's no reason. We have to say we are South Africans primarily, and we are wasting a bucket load of money on systems that do not serve the interests of the public. They serve the interest of the few, the business incentives and so forth, and we need to put our heads together and work out what we do now and what we do next and next and next, but not either or.
Let's see if there are any questions in our audience, in our live audience at the moment. Do we have I see a hand going up in the middle here. Thank you, Zandi. Let's take the question from the lady, okay, from the gentleman in the middle.
Morning.
Morning.
Morning, Chris.
Yeah, it's on.
The private healthcare system has become too expensive and unaffordable. And as a result, anything that comes as an alternative like the NHI will always be seen as a messiah. Despite all these challenges and unanswered questions, but what are we doing to make sure that the private medical aid system, the prices are regulated? I know there's a Council of Medical Aid Schemes, but I'm not so sure if they are doing what they're supposed to be doing. Thank you.
All right, thank you very much for the question about private sector reform. what is being done to prevent overpricing and everything that you've spoken about that characterizes
Okay, so I don't sit on the Council for Medical Scheme, and much as you think they report to the Minister, they report to the Minister when they're ready, when they've got a report, and they work with industry and they deal with various things. So I'm not a member of the Council for Medical Schemes, and they work more closely with Stan than they would work with me. But what I do know is that when they do their research and their various subcommittees, they prepare reports which they then come and meet with the Minister. I know because they're busy trying to meet the Minister at the moment about a number of issues where the Council, not the Registrar, where the Council has now taken decisions and they are ready to present it to the Minister. But maybe Stan.
Yeah. No, certainly to cap the costs, and Nicholas referred to this, and I wanted to call you Prof for the first time in a public environment. The wastage that is being referred to needs to be nipped in the bud. And we have examples within the GEMS of two of our options where we introduced something called care coordination. And that's what Nicholas was talking about. We have mothers, they've got little children. The child starts having a snot, running nose. You'll hear the mother say, I took the child to the pediatrician. That can be sorted at primary health care, and we save costs. So what we have demonstrated with our two options, which is emerald value option, we call it a discount efficiency option, and Tanzanite 1, the savings on downstream costs, just by introducing care coordination, around 17%. Very, very significant. To the extent that our emerald value option, we are able to have, for the same benefit that you get on the standard emerald option, a discount averaging around 1,000 rands per family. So which means you would be better off by just changing from emerald option to EVO, but you must accept the care coordination as one of the things, which is referral system, using networks, right? Which is some restrictions, but the benefits are there. So it's examples like those that we can introduce to cap the costs. And some of the big are the downstream costs. And remember, universal healthcare coverage starts at primary healthcare. And that is where the solution lies.
On that note, I just want to ask you a question here, Teshlin, because this is clearly a fairly irate medical aid member who says we are still being fleeced. Nothing has changed since HMI, which is the market report. Did Netcare change anything in how they operate post-HMI that addressed the issue of supplier-driven demand?
I think we're always working towards getting some level of efficiency back in the system. And I think to your point, Nicholas, these things don't happen overnight. And there are lots of interventions that need to be put in place to actually make sure that the system operates with efficiency. We've changed a lot in Netcare, and we've also introduced a few added solutions to actually address what we need to address. Are we there yet? I think we've got a way to go, like any other private healthcare system. But we have an entire ecosystem that we need to look after as Netcare. Quite often people just refer to us as a hospital group, but people don't realize that we have mental health facilities, we have primary healthcare facilities, we have wellness facilities, and making sure that this entire ecosystem is as efficient as possible is what we're trying to do right now. I think digitization is quite key. Nicholas just spoke about it quite early on as well. Quite often if you go to your primary healthcare facility and you go to the hospital, those two don't talk to each other. And that's where some of the level of inefficiency actually exists. And what we're trying to embark on right now as Netcare is being able to give you that single patient record across that entire ecosystem. Yes, we would love to do this across South Africa like Nicholas is trying to do. But right now, we're trying to get that level of efficiency for you as a patient to be able to carry your record wherever you go. I believe that's going to help. Is it the answer? It's not the silver bullet, but it's actually going to take us a long way in terms of patient experience right now.
I mean, that's a very good point. Can we take another question from the room at this point? Okay, we have a hand up here, one here in front. Oh, yes. Sorry, good morning.
I'm in favor of it, but I'm talking from overseas,
Sorry to interrupt you. Could you just speak a little bit louder, please?
I'm in favor of, NHI, but the big problem we have, if you look at the case records in the UK, I'm from Italian region.
Right.
My main concern is my mother-in-law couldn't get the cataract operation done because it didn't form part of the basic benefits. And she had to pay that privately. So, we're there to help the out of 40, 50 million, 100%. But if we have this type of scheme, it's going to mean we have to do actuarial calculations. It's no good just bringing out the law to say, okay, now we're going to do NHI. We've got to see the funding mechanism. If we look at the only successful one, in my little opinion, is Costa Rica. Anthony, you know that.
Colombia.
Costa Rica is one of the highest percentages of people that are paying from the sugar cane places towards NHI. And it's working with 6 million taxpayers here. How are we going to fund this? It means it's going to be a higher tax for everyone. We're already bleeding as it is. So, we need to do more homework. We've got to do proper actuarial calculation. Don't bring out just the law and say we're going to start now. And if that happens, yes, it can work. But then there's informal people that are earning money, but they're not contributing to tax. No, I'm not pointing fingers. Anthony knows my background. I'm saying it's got to be equitable. Otherwise, it's not going to work.
It's a good question. Nicholas?
Okay, so first of all, poor people do pay tax, and we just need to recognize that they do pay tax. They pay VAT, they pay petrol levy, they pay every time they get in a taxi. Proportionate to what I pay, poor people pay a lot of tax, and we need to give them credit, even if it's a small amount of rand. Yes, we pay a lot of tax, I pay a lot of tax, and I expect to get something for that tax. But if I also pay a contribution to a medical scheme, I expect to get something back for that. So I go to a medical scheme. I'm unfortunately not a member of yours, Stan, because I joined the public service over the age of 60, so bad luck. So if I join a medical scheme, they have done actuarial analysis on a pool for a comprehensive package. So they will look at what benefits in that group of people. And then they'll go down through their options. You heard Stan talking about the various options. And at a lower option, there's a lesser number of benefits. So that's what the NHI says. It says we will progressively increase the benefits that are paid for from the fund. So on day one, what can I pay for with the fund? Well, I can pay for primary health care, I can pay for this, I can pay for that. Where do I get that money from? Well, I get it from the provincial equitable share and the conditional grants. I get it out of what's currently spent in the correctional services. I get it out of wherever it's currently sitting in the public service. But there comes a day where I say, okay, now I'm covering everybody for this package, these set of benefits. Where do I get the additional 10 billion from? Well, I start with the tax credits. Why pay me as a medical aid member to try and incentivize me to be on a medical scheme when you should be spending that money on getting poor people better health care? And that's a decision we have to take. We also can get to a point where we say, okay, at the moment, 1.2 million public servants contribute to GEMS and other public servants, but 75% of that contribution is paid by you as tax through the public service as the employer contribution to the public service. Why don't we just redirect it through the National Health Insurance Fund and we buy those benefits through the fund? So the timing and how the law works and how the regulation works, it can't all happen at once, clearly. That would be crazy. You'll break the system. We know that. So we do need to calculate which benefits, what's the cost of those benefits, what is the health technology and the products that are used in that benefit, which they use in the medical schemes. We are busy with health technology assessment all the time. You see, we get in trouble in the media because we reduce the price of medicines. We have the cheapest antiretrovirals in the world. We've reduced the cost of to the state of the vaccines lately. Other people get upset with us because that's their profit margins gone. But that's what you have to do. You have to say, if I can get big data on salicylic acid and paracetamol or whatever the case might be, I can reduce the costs and reduce the costs. And then I can add more benefits because I'm using the same money. If I can rationalize the lab test and stop asking for a full blood count when I only need a hemoglobin, I can reduce the cost. That's what the schemes are doing all the time. Why can't we do this for one big scheme for the whole country so that we don't have to have these options and choices and things? And the answer is we can, but we can't do it all at once. You have to do it slowly but surely, and that's what we're busy with at the moment.
Joanne, I
Mr.
just-
Crisp, yeah,
I just
quickly,
wanna-
Anthony.
I just want to add to that is that, Albie, thanks for the question. I think the reality is, and Nicholas pointed this out, that at the start of NHI, you're not going to have a set of benefits that matches what you get out of medical aid. Right? I think we must expect that the NHI benefit framework is likely to be very, very modest to begin with. Over time, it would likely improve if it's administered well. And for that reason, Nicholas, I'd like to submit that I can't see us doing away with health insurance products and medical aid schemes because it meets a very specific need, within the private sector, those 9 million participants. So we can't simply abolish those products. They have to coexist until such time that NHI meets.
That's what the bill says.
Yeah. And so the bill, I think, Section 33 actually says only when NHI is fully implemented, and we are a long way from that. So we don't need to be in panic mode.
No.
Medical aids will coexist, but I think what I'd like to encourage employers to is start thinking ahead, and it's something that Nicholas said, that it will change. Emphasis on it will change, meaning that the change is coming. I don't want us fighting the change. I want us embracing it and actually working together to get you into the other side.
Anthony, I'm actually going to wrap it up there, and I want to thank everybody for their contribution today. It has been quite an intense discussion. It's been highly informative, and it's at this point that we wrap up these Business Day dialogues live in partnership with ASI Financial Services on the future of healthcare. Thank you to our incredible panelists for your insights. It's really been fascinating listening to you and learning about the NHI and how it's taking shape. Thank you so much to our viewers in the room and our viewers joining us online for your engaging questions. I think I could have just gone on taking a number more. My hope is that you leave this conversation with a much clearer picture of what the architects of the NHI hope to achieve, a better understanding of how it's likely to unfold and how it'll affect your life and that of your family members personally, including some of the ongoing conversations in the medical community as to how this bill is going to be crafted, how it's going to be enacted in the future, and what kind of evolution it's going to undergo during that process with the input of everybody involved. Remember to keep a close eye on developments at the NCOP, to keep asking the right questions as South African residents as this project progresses. From me, Joanne Joseph, thank you so much for watching. Thank you to our partners, Business Day and ASI Financial Services, for this fascinating discussion. Take care. Bye-bye.